So, and of course, I think for today we will do the round table. I have some list of the question, but before that, Dr. Silva, please introduce about what is the HIFU technology, because some doctor they don't know about it.
Okay, maybe I mean I've got a full lecture, but maybe we won't talk about lecture. Now I am a fertility specialist. Now I have been doing IVF since 1997. So this will be my, I don't know, 27th year, I think, of doing IVF. And but my first love is actually laparoscopic surgery. I started doing laparoscopic surgery in 1994. Actually, I was trained in Changan Memorial Hospital under Dr. Lee Chi Long. At that time, Dr. Lee Chi Long was not the boss. His boss was Professor Song. So I went and trained under Professor Song, and then I came back and then I do laparoscopic surgery. In Malaysia, I probably do the most laparoscopic surgery. I've done almost 7,000 cases. I do everything from radical hysterectomy to sacrocolpopexy to everything. Because nobody wants to do, so I do everything. But I also do IVF, not as much as I would like to, but maybe about 150 cycles a month, just to keep me happy. I know what's happening. So when Chongqing invited me to do HIFU, I thought HIFU is a waste of time, because in Malaysia we have been doing HIFU for the last 15 years. In the university hospital, but the HIFU that they were doing is something called MRI HIFU. I'll explain to you the difference between the two. And this one is different. This is ultrasound-based HIFU. So for about 1.5 years, the people were trying to get me to come and get to learn about HIFU. And I said, no, I'm not interested. Then in 2019, one of my friends said, okay, let's go to Chongqing. I will show you what this HIFU is all about. So I went to Chongqing. I looked at their system and I said, wow, this looks very, very interesting. And it is interesting to me because you can treat adenomyosis with it. And all of us who do IVF, we know that our bottleneck is adenomyosis. And adenomyosis, we've got nothing to offer. Adenomyomectomy is not a very good operation. And there's a worry of uterine rupture. So when I looked at it, I said, maybe we can incorporate this into my practice, which is laparoscopic surgery as well as IVF. So that's when I got interested. Then I went a few times. I went to Korea to visit some friends there to see how they run the center. I went to Hong Kong, Felix Wong, and then Singapore. And I said, okay, maybe we'll bring this technology. So we actually ordered the machine in December 2019. But unfortunately, 2020, COVID came. So we couldn't implement it until July 2021. Last year, we started HIFU in 2021. So now today I did my 186th case. Now, the concept about HIFU is very simple. We are just using ultrasound energy and we are increasing the temperature of cells in the fibroid, in the adenomyosis or any tumor, and killing the cells in the uterus. It is actually a non-invasive therapy. That means the patient doesn't have any scar. She just lies down prone on a pool of water, and in the water you have that bowl which contains the probe that will then shoot energy into the uterus, and we locate the fibroid and the adenomyosis, and then we kill the cells. That's how HIFU works. So what is the difference between MRI HIFU and an ultrasound-based HIFU? I can show you the slides, but I just talked to you all. Maybe if you want me to, I'll show it later. The difference is this. The transducer that we use in ultrasound, first of all, the difference is MRI-based HIFU, the imaging technique is MRI. Ultrasound-based HIFU, the imaging technique is ultrasound. So in ultrasound HIFU, we look at the uterus using ultrasound and we shoot using ultrasound. Whereas in MRI, we look using MRI and shoot using ultrasound. So the difference is that MRI, is very good. You can see very well, because then nothing can beat the beauty of how clear an image is with MRI. Ultrasound is not so good. But the problem with MRI-based HIFU is that that you have to sit in a tunnel. Patients don't like to sit in the tunnel for 3-4 hours. And more importantly, the transducer that is used in the MRI-based HIFU is different from the transducer we use in ultrasound-based HIFU. In the MRI-based HIFU, they have got 265 small transducers, and all these transducers will shine, and then you focus a beam into a spot. So whereas in an ultrasound-based HIFU, it's just one big bowl and it shoots. So the energy, strength of the energy from the ultrasound-based HIFU is much stronger than that in the power is much stronger. So you can actually give a lot of energy in the ultrasound-based HIFU compared to the MRI-based HIFU. Now, I'm saying this from theory. I've never seen an MRI-based HIFU work. I wanted to go to a place to actually look at it, but I have never had a chance. But that is the problem. When you have a powerful machine, you can kill more. You can also treat more than not so powerful. The other big difference is that you know that MRI is in a tunnel and the bowl is below, and the bowl cannot move very much, very little movement. And actually the bowl actually can turn the energy one up and down. Whereas in ultrasound-based HIFU, it's open system, so you can move the bowl, so you can reach much more bigger area. But I think what is the most important thing for us gynecologists is that in an MRI-based HIFU, it is done under non-real time, which means that they first do an MRI, they see, hey, this is the spot I want to kill, and then they switch on the machine, and when the energy is being given, which takes 20 seconds, you cannot see what is happening inside. You can use heat wave, but you cannot see. So if the patient moves, the beam may be a dangerous position. Whereas in ultrasound-based HIFU, we do it real time. That means I am looking every second that I'm shooting the energy. When 1 second I shoot, that 1 second actually the image is still, but immediately if the patient moves, I can stop it. So that's the biggest advantage. So you can actually go to very near to nerve, you can go very near bladder, and then you can be very safe and you can give energy in a very big area. I think that is biggest advantage, especially for fibroids. Because my patient lie down under sedation, they give sedation, and the patient lie down, she's actually talking to me when I'm doing the procedure. Say if she coughs and the thing move, I can stop the energy so that it doesn't hit something dangerous. So I think that is the biggest advantage. So the non-perfusion volume, which is the area that we kill, that is not has got blood, is much bigger in ultrasound-based HIFU compared to the MRI-based HIFU. That's maybe the reason why ultrasound-based HIFU is more successful than MRI-based HIFU for gynecology. In my country, MRI-based HIFU has been available in the university hospital for the last 15 years, and they've only done 40 over cases. The reason is they reject all the cases. It's not suitable, not suitable. Whereas in MRI-based HIFU, my rejection rate is maybe 5%. Most of the patient I can do the MRI because I can see, I can shoot. That's the reason why within 9 months, I've done 186 cases already. In fact, tomorrow I've got one, day after tomorrow I'm doing 2. So that is, I think, the basic difference between the two. So I hope you have a good idea. If you want to, I can show a video how the whole process works. But if you don't, then I don't have to show the video. So that is basically the whole concept about HIFU. So if you have any questions, maybe you can ask.
Yes. Dr. Veena, do you have any questions?
No, because this is the round table, please be free to ask so that it's not a lecture. I don't want to give you all a lecture. If you have anything, any question, just ask, then we can discuss it.
So I have the questions. So as you are the laparoscopist, we know that sometimes we do the surgery faster than like clicking the computer to burn the tumor. So what about your opinion about what is the big difference between laparoscopy and HIFU?
Okay, good question. I always tell, because I tell my patients, I can do everything. I can do laparoscopic surgery. I can do laparoscopic surgery to remove the fibroid. I can do laparoscopic surgery to remove the uterus. I can also do HIFU. Now, the advantage and disadvantage are like this. If I were to do laparoscopic surgery for you to remove the fibroid, the big advantage is you remove the tissue. I can take out the fibroid and I can send it for histopathological examination. I know that when the fibroid is out of the uterus. There is one big advantage of laparoscopic surgery. The second advantage of laparoscopic surgery, you're sure that the tissue is gone and you can stitch back the uterus. But what are the disadvantages of laparoscopic surgery? Of course, there's possibility of bleeding. There's a possibility, a small possibility that you bleed so much that you may have to remove the uterus. But as an infertility specialist, more importantly, is I make a cut on the uterus. I take out the fibroid. I stitch back the uterus. There is a risk of uterine rupture. So it's very, very rare. But more importantly, most of the time, 80 to 90% of the time, the patient will have to have a cesarean section. Many people, I mean, if you do a big fibroid, you don't want the patient to normal delivery. So these are the advantages and disadvantages of laparoscopic surgery. And in a lot of patients, laparoscopic surgery is quite fast. I can do a laparoscopic myomectomy sometime within 1 hour. If it's just a 5 centimeter or 6 centimeter fibroid, but if multiple fibroid, maybe it takes me 1.5 hours, maybe 2 hours. Of course, there's another problem of morcellation, which is controversial. You have to put inside a bag and then morcellate if you really want to prevent, parasitic fibroids or spread of fibroids. So these are the advantages of laparoscopic myomectomy. So for HIFU, what is the advantage? Okay, one big advantage is there's no scar in the abdomen. It is non-invasive. The patient can do today, tomorrow she can go back, day after tomorrow she can go back to work. Those are the benefit. But for an infertility specialist like me, the biggest advantage is I don't cut the uterus. I don't make an incision and cut the uterus, so the patient can actually have a normal delivery. But I always tell them the biggest disadvantage is I cannot guarantee that your fibroid will shrink. There is a 5% risk that the fibroid may not shrink, and you may end up with a surgery later. Another disadvantage is we don't have histopathology. That means we don't take out the fibroids, and the fibroid will be there for maybe 6 months, even up to 1 year. That's an advantage. That is a disadvantage when the fibroid is there. But after about 6 months, when the fibroid is about maybe 30, 40, 50% smaller, the patient can start getting pregnant. Whereas in a myomectomy, you usually tell patient about 9 months. Nobody really knows 6 months to 9 months. So these are both the advantages and disadvantages. So for patients who don't want to get pregnant, say single women, I see a lot of single women in their 40s with fibroid. They don't want to do surgery. They're worried that the uterus will be removed. They like HIFU because you do the HIFU, you shrink the fibroid, they go into menopause, everybody is happy. But those young patients who want to get pregnant, then they have to balance which one they want to, which is the advantage. They want to do myomectomy or they want to do HIFU. I leave it to them. Usually I leave it to them which one you want. So that's basically, that's how I explain to them the two types. I said I can do both. I have both the facility. You decide what you want. I'm not forcing you to do one or other.
I see.
But adenomyosis is different. Adenomyosis, they got no choice. Because adenomyosis is between adenomyomectomy and HIFU. HIFU is far better. Adenomyomectomy, I don't like the surgery. It's so difficult to do. I don't know how much I'm cutting. I'm worried about the patient having uterine rupture. So for adenomyosis, the choice is very, very little. They probably have to do HIFU. But for fibroid, they have a choice. Okay, Olarik, back to you.
Yes. My question is, so do you do like a step of the treatment same as the traditional one? I mean, maybe we can do the IVF and freeze of the embryo before.
Yeah.
Before the treatment, because after the treatment we have to wait like 6 or 9 months. So it's the age of the patient is going.
Yes. Okay, there are two groups of patients who come to see me. One group of patients is they are young, like the girl I showed you just now. She's just 35 years old. She's got not much of a problem of infertility. She just wants the fibroid to be either removed or shrunk. That patients we are not thinking of IVF. But if the patient is somebody who is thinking of IVF, then we have to balance. Majority of the time, if I can actually collect the eggs, I would advise them to do the IVF first, because you need 6 months to 9 months before you can, do IVF. But some patient, like one patient, the fibroid is so big, we cannot get to the ovaries. What do you want to do? So you've got to shrink the uterus first. And after 3 months, it shrink. I can get to the uterus, then I do the IVF, collect the eggs, keep it, freeze the embryos. Then we can transfer it maybe 3, 4, 5, 6 months later. As far as adenomyosis is concerned or endometriosis is concerned, many of them are in the late 30s or early 40s. I tell them better to do IVF. I do the AMH first. If the AMH is low, I'll tell them do IVF, collect the eggs, freeze the embryos. Then we do HIFU, shrink the adenomyosis, and then maybe 6 months to 9 months later, we transfer. So it all depends on at what stage of the life they come to see us and how is it, which is more important. Many of the adenomyosis patients are actually infertility patients, so they will be the one that will be required to do IVF. But if they are young adenomyosis, I've got 25-year-old lady with adenomyosis, not married, but that is a different issue, or young patient who actually her aim is to shrink the adenomyosis so that she can get pregnant on her own. Then we do the HIFU and then ask her to try to get her pregnant on her own. So it depends on the situation. So even in fibroid, it's the same. Fibroid, the majority of my fibroid patients are not infertility patients. They are actually patients who are having their fibroid, and all the doctor tell them go and remove the uterus, and then they say they come to me to shrink the fibroid. Very few. In fact, the one I saw today, there's one lady who had a previous myomectomy in 2017. She just got married and she got recurrence of fibroid. Those patients we will do HIFU to shrink the fibroid. If they are new patient with fibroids and also infertility, then we will see what is the best option. It's not that everybody we need to do HIFU or everybody we need to IVF. We will see which is the balance of the patient for the patient. So younger patients, I would aim for shrinking the fibroid and then allowing them to get pregnant on their own. Older patient, I will consider doing IVF, freezing the embryos, and then doing the HIFU for fibroid or adenomyosis.
Wow, so very interesting. Dr. Pimpaka, do you have any questions or anything you want to share, because now you are only one Thai doctor in this room who have the experience on HIFU. Maybe she's not convenient for now. So I have another question. So in your experience, do you have the recurrent of the fibroid?
I mean, I've been only doing it for the last 9 months. So far, no recurrence. But I have patients whom the treatment was not effective. We know it's not effective. These are fibroids. These are fibroids, they are vascular fibroids. That means on MRI, they look white, and on contrast MRI, it also looks white. And when we test, we thought we can do HIFU. The way we test is we usually do something called an oxytocin test. We put in the color Doppler, and then we put up a drip, we give them oxytocin, and we see whether the blood decreases or not. If the blood decreases, then maybe they can do. So I've got a few patients we thought that it will work, but it didn't work. So now we are, how do I know it didn't work? When I do the HIFU, the ablation was not good. We have got something called sonoview. We can see whether the blood flow is bad or not. Then the next day when I do an MRI, we can see that the ablation is not complete. It's patchy, little bit here and there. So I know it's not going to succeed. So these patients will need to come back for surgery, but they have not come back yet. Adenomyosis is the same thing. Not all adenomyosis works. I realize that some adenomyosis that has got a lot of big leaks. That means they are all old adenomyosis that has been bleeding inside and they form big leaks. Those adenomyosis are the ones that doesn't work. So those kind of patients, they will probably need a second treatment. I was speaking to Dr. Choi in Korea, who has been doing it for the last 4 or 5 years. He said 15% of his patients have a second HIFU. So that means I have not done a single case of second HIFU yet, but 15%, he said his cases 15% he will do a repeat HIFU. The reason is first time not complete or ineffective, or it is not coming down, so it's not shrinking, so he will do HIFU. So I have no experience to repeat it yet, and I still haven't done a patient that I thought it failed and I have to do a laparoscopic myomectomy or even a laparoscopic hysterectomy. So far, not yet. Maybe in the next 6 months, I may have that kind of cases. But I have done many cases whom we thought it was cannot do HIFU, and we have taken them for surgery. And actually, they were vascular fibroids, were bleeding a lot, and then we took a remove and then do the laparoscopic myomectomy. Okay,
wow, that's a very interesting issue. So we know you are the expert and you have a lot of the experience to talk to the patient. So my question is how to counseling the patient about if it doesn't work, right? Because we know that in Thailand we have a lot of the lawsuit if the treatment is not success. So in your experience, how to talk?
Yeah, I actually tell all my patients there is a 5% risk in fibroid. There's a 5% failure risk. In adenomyosis, there's a 15% failure risk. I tell them this is the studies, this is what it is. You must accept it. If you say I can't accept it, then I'm not going to do for you. You must accept the fact that you have got a chance that this fibroid may not work, and you will need surgery in future. So if and it is written down in my consent form and they know it and then they sign it. So there's a big advantage in my country at the moment is because almost 95% of my patients HIFU is covered by insurance. Because it is covered by insurance, they're not coming out with their money. It's okay. Fail, I do operation, is covered by insurance. So that way I'm protected. But I've got a small percentage of patients who pay cash. So I tell them, you must be sure, because if this money you pay for your HIFU doesn't work, you still have to pay money for surgery. Are you okay or not? If they say, no, I'm not okay, then better do surgery. Because surgery, I know I've been doing it for 30 years. I know surgery will 100% successful. Only risk is you bleed and you have to take out your uterus, but it's successful. Is it? So this is how I counsel them. So I'm lucky in that sense. If everybody is paying cash, then I'll be very, very careful to do HIFU because I'm just starting off. I'm new. You know what I mean? I'm new, and I'm also asking myself, am I doing right thing for my patient? I've been doing operation all these years. Patient are well, no problem. Now I'm doing something new. If the patient is not well, or if the fibroids start growing back, I feel very bad. In fact, recently I've got one patient. The fibroid didn't shrink as much as I wanted. So I'm thinking, did I do the right thing for the patient or not? So I am upfront with them. I tell them this. I tell them, I'm not forcing you to do HIFU. You want, I can do for you. But understand that this is the risk that you have to take. See, but because it is paid by insurance, I think nobody complains. So far, nobody complains.
I see.
In future, they may.
So I have another question. Some doctors said during the shrinking of the fibroid, the patient have some pain. So is this true? Is this pain during the shrinking?
It is not. It is not. Surprisingly, it is not. I've now done almost 100 fibroids. When we do uterine artery embolization, that was the complaint. You see, when the uterine artery embolization, the problem is we block off the uterine artery. The fibroid is actually strangulated. It means it doesn't get blood supply, so it becomes painful. Whereas in HIFU, the technology is different. We actually kill the cells in the fibroid. So the fibroid is dead, inside is dead, so it doesn't cause pain. The only problem is when we are doing the procedure, the patient will feel pain. That is the only thing I find it, especially adenomyosis, because when we are pushing the energy into the adenomyosis or into the fibroid, at the beginning, they won't feel pain. But when the energy starts expanding, then they will feel the pain. Many of them can say pain up to 8. We keep a score. What is your visual analog scale? How from 0 to 10, what is your pain when during the procedure and after the procedure? Many of them say 7, 8, 9. Some even say 10, their pain. Because that sharp pain is there, however much we give the sedation. And we don't want to give too much sedation because one of the biggest complications about HIFU is nerve injury. We don't want to give too much energy that it splinters and cause nerve problems. So when we keep asking them, you have pain on your leg, you have pain in your thigh or not? If you have, we move to a different spot. We keep moving to the different. Same thing when they say they have got skin pain. If they say you have skin pain, then we move to a different spot. These two, we keep talking to them, you see. So, so that is the reason why I don't have a single patient who say that she has pain in the uterus after the HIFU. Not even a single one. I've done 186. I've done 186. So the pain is during and the day, probably the day after the surgery. After that, there's no pain.
Wow, that changed the
The concept is different. The concept is
That
different.
changed.
Yes.
That changed. This is good news. So I have another question. Everybody asks about the cost effectiveness.
Yeah.
We know that the price is a little bit higher than the laparoscope or export. So what do you think?
Yeah, I mean, this is what I keep asking myself. I keep asking myself, I can do this surgery laparoscopically so well. Say you see a 5 centimeter fibroid. If I do a laparoscopy, 1 hour, I take out the fibroid. The fibroid is out, I repair. Whereas if I do HIFU, I'm worried 5% it might not shrink. I have to wait for 6 months, 8 months to go down, whether it's worth it or not. This is the patient's decision. As I said, in this country, I'm lucky because it is paid by insurance. So patients say, okay, I tried this, it didn't work, I go and do surgery. It's okay, you see. But if the patient is going to pay the money, I will be also very, 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 very worried because they are going to pay. In my country, we have decided that they will cost about the same amount of money, laparoscopic myomectomy and HIFU. So the patient paying is about the same, but because it's paid by insurance, so they are okay. You know what I mean? But if you're paying by cash, then it becomes a bit difficult. And also, we are all doctors. We all want to make money as well. So if you ask me, I've done 185. I spent many hours doing this 185. Ever since I started HIFU, I got no time to exercise. Every day I go back at 7 o'clock or 8 o'clock. Today I started my HIFU at 7 in the morning. By 9 I finished 2 hours. But usually these 2 hours I'll be starting now, 5 o'clock. I finish at 7. I only go home at 7:30 or 8. So every day is very tiring. I'm working harder than ever because the time taken is longer, you see. So I keep asking, is it worth it for me or not? But because I want to be the pioneer in this country, I said I will do it and become good at it. So for the patient, I cannot answer this question until I see maybe another year when I see all of them coming back and seeing how they are. For fibroid, yes, you can question that. But for adenomyosis, you got no choice. I tell them, this is last resort. The next to this is remove uterus. Which one you want? So they will do the HIFU. See, for fibroid, you have a good option. Myomectomy is a good option, but they will have to make the decision. The ladies, I like to do are the ones who are 45 to about 50 years old when they have big fibroids and they are not bothered about pregnancy. So we can even if I kill the big ones only, leave the small ones behind, it's okay. They were going to go into menopause and they will shrink. Now, those are the best patients. The younger patients, I let them make the decision.
I see. So there's many questions. My friend sent me by the message. So another question is, do you treat all of the fibroid you see in the MRI, or just only some big fibroid that affect the symptom of the patient?
I try to treat all. I try to see all the fibroids. So because the patient will ask me why did you? But unfortunately, on the ultrasound, it's very difficult to see the small fibroids. You have 2 big fibroids here, and then you have 1 small fibroid. It's very difficult to see. And then if the fibroid is very, very posterior, very close to the sacrum, you cannot reach it. Very difficult to reach it. This is one of the cases I do in the morning. So my aim is, that's what my teacher teach me, is to try and do as many as you can. If you can see it, just give some energy, it will die. Of course, we aim to do the bigger ones and the ones that affecting fertility, but our aim is actually to do as many fibroids as possible. The multiple fibroids are the difficult ones because you got to go from one to another. And in an ultrasound, if you do abdominal ultrasound, you realize that it's not so easy to see all the fibroids. You understand? So you got to go from one plane to another one by one. It is very tiring. The easy ones, even if big 10 centimeter fibroid, even 20, I've done even 30 centimeter fibroid. One big fibroid is very easy because you know the extent, you can just treat. But when you have multiple, you've got to go and finish this fibroid, then you'll decide how much energy to give this fibroid. Okay, finish, then I go to the next fibroid, then go to the next fibroid. Good. Oh, it's very tiring and it's time consuming because to get to one fibroid, you have to position the patient again. You have to put the probe in the proper position, and then you have to treat the fibroid. And then you position the patient again, do the other fibroid. So it takes a long time to do that.
I see. I see. So another question is, let me check. Okay. So in your opinion, what is the contraindication of the HIFU?
Okay. I mean, if you look at the Chongqing's lecture, there are a lot of contraindication, but in my mind, there are a few contraindications. Okay, the first is for fibroid is a vascular fibroid. I don't want to do vascular fibroids. Now, what is a vascular fibroid? A vascular fibroid will look white on the T2, and on a contrast, it will also look white. Now, why these fibroids are very difficult to do. They take a long time and they don't absorb the energy. So if I see a white fibroid, I don't want to waste my time. I say I'll do laparoscopy. That's why my first contraindication for fibroid. The second contraindication for fibroid is a pedunculated fibroid. The pedunculated fibroid you cannot do because first of all, it's difficult to do, and next it may die and drop off into the abdomen. So you don't want to do a pedunculated fibroid. Large subserous fibroids, if it's a completely subserous fibroid, you can do, but you must warn the patient that it will take a very, very long time for the fibroid to become shrink because it doesn't have the muscle tissue around it. So absorption will take a long time. So we will tell them, if it's one of those patients who say, I want to see my tummy small very fast, then do surgery. So if it is a large subserous fibroids, it's not a contraindication, but you must be very clear with your patient that you will need to treat. So these are some of my thoughts. But other important things are patient with a lot of multiple scar in the abdomen, especially if the scar is very big and very thick. First of all, ultrasound cannot see through the scar. It will be very, very difficult to see. Second, the energy will be absorbed by the scar and it will cause burn in the scar. But we still have done on big scars. We tell the patient we will try. Some patient insist we will try. If I do the scope and the scan and I can see the fibroid very well, or I move away from the scar and then look at it, I can do, then I can do. So scar is not a complete contraindication, but it is one of the contraindications. Of course, the other thing is patient lying down. They have to lie down in the prone position in a cold water bath. The water is 14 degrees. One patient said, why is it so cold? But it's because I need to cool down your skin, is it? So you must be able to lie down there for 1 hour, 1.5 hours. If they cannot lie down, then we cannot do that. That's one of the contraindications. So these are basically another contraindication is, another very important contraindication is if the patient have had a previous surgery, we must make sure that the intestine is not stuck in front of the uterus. It's an absolute contraindication. That means if you see there is a bowel in the pathway, no way you can do it because that means you're going to perforate the bowel. So patients, especially who have got previous surgeries, we are very careful to make sure the bowel is along the way. So because the most important thing is a pathway. A pathway means although the focal point of the adenomyosis, the focal point of the HIFU is at this point. This point is where it will heat. Along the way, you can get heat. So if you have a bowel there, you can actually accidentally perforate. So this is a pathway. So we look at pathways. Sometimes adenomyosis, the fibroid or the adenomyosis may be on a retroverted uterus. The uterus is bent backwards, and these are difficult ones because when the uterus is bent backwards, then you cannot get a good pathway to reach the tissue. You need a big bladder, and then we need to see whether we can get up. If you can't get a pathway, you can't do it. So these are my contraindications for saying a patient that I can't do it for you. Small uteruses, small adenomyosis are more difficult to do than big ones. Big ones are the easy ones because big ones, they sit on the abdomen and the probe can be very close to them. Small ones, we need the bladder to give us a window to reach them. So it's much more difficult to do smaller fibroids and smaller adenomyosis. So location of the fibroid is also important. The more posterior the fibroid, the more difficult is it to do. So that's the reason why when we do HIFU, we do something called simulation. We do a MRI first, and we take the MRI into the HIFU system. We look at the MRI, and then we look at the ultrasound, and we map it, and then we see. Sometimes certain patient like very obese patient, when the abdomen is very obese, you can't, you know, the ultrasound you can't see. So we use the MRI as a guide and we take measurements. So we take measurements. So now you know this is how it is. You can't see very clearly, but you know that is the top, that's the bottom. The fibroid is there. So we use that as a guide to shine it. So we go in the safe area. So we use a lot of MRI measurement to use it in the ultrasound to estimate where the fibroid is. So it's not always you can see clearly. Thin patients are nice, you can see clearly, but very thick patient, very obese patient, the vision may not be very good. Then you will have to use estimation, and then if you cannot see, then you cannot do it. You know, so vision is very important.
So what is the longest operation you did for the HIFU?
We did one for about 4 hours, 4.5 hours. This was a lady, actually I did with my teacher who was with here, Dr. Huang. That lady had almost 20 centimeters cervical fibroid. Huge cervical fibroid. We were very scared to do operation on her because we thought she would lose the uterus. She wanted to get pregnant. So okay, we say we'll do HIFU. So that patient we actually took 4 hours because we were trying to ablate the whole fibroid. I did one 30 centimeter uterus. The uterus was up to 30 weeks size, 30 centimeter. Refused to do surgery completely. She wanted HIFU. So that patient, we did only half. We did the bottom half of the so bottom half, we took about 3 hours to do the bottom half. And then once the uterus come down, we'll do the other half. So she agreed to do that. So we decided to do that. So the machine has got a limitation. It can only give 300 seconds of treatment. On the average, to give 1,000 seconds, 3,000 seconds, 1,000 seconds, usually it takes about, if you do fast, if you're real fast and the patient doesn't complain of pain, it may take about 60 minutes, 60, maybe 90 minutes. So for 3,000, you can do up to 4 hours, but most of the time after 2,500, we already give up already. Don't want to give anymore because we're very scared. Too much energy means too much splinter. We are worried about nerve injury. We don't want nerve injury. So we usually stop at around 2,000, 2,500. This is my experience. My experience is not big. I'm sure people like Eileen and all that, they have done so much more. They will give you more. But this is my experience in the last 8-9 months.
Oh, Rosie, she's coming. Rosie, hi, สวัสดีครับ So I have another question. So in your experience, so how many patients convert from laparoscope to HIFU? Your own patient. How many percent do you estimate?
You see. Before the pandemic, I used to do 300 cases of laparoscopic surgery a year. On average, I will do 25 to 30 cases a month. I also travel a lot, you know, I travel a lot, so sometimes the traveling time. Now I am only doing, I think it's because of the pandemic, I'm only doing probably 200 cases. The last year I probably did only 100 plus cases. This year maybe 200. So I am doing far more cases of HIFU than laparoscopy, because when I tell them, most people want to do HIFU, so I'm doing HIFU. So I as far as fibroids and adenomyosis is concerned, 80 to 90% do HIFU. They choose HIFU rather than laparoscopic surgery if I give them that option. Of course, I also do a lot of other things like endometriosis and you know, sacrocolpopexy and cancers. Those are the ones I'm still doing. So I'm actually doing lesser laparoscopy now compared to before, but also because of the pandemic, we don't know. So if you ask me how many percent of my fibroid and adenomyosis that I could have done laparoscopy, I'm doing HIFU, is a very high percentage. Actually, it's very high percentage, because patients choose it. It is very attractive for patients to do HIFU. As I told you, that is because in this country it is still being paid by insurance, so that is maybe the reason, is it? So if it is not paid by insurance, they're paying cash, then it's also the way we talk to the patient. You know, and I know how you talk to the patient. If you talk favorably towards HIFU, they will choose HIFU. They will sometimes ask you, which one do you think? I always tell them, if money is not an issue, I would choose HIFU, because if HIFU works, you have got no scar, nothing. You have your uterus. If I do laparoscopy, you have a scar. There's a small risk of bleeding. There's small risk of removal of the uterus. So I would choose HIFU. The only problem is now money. If you whether you want to spend that money doing HIFU, and then if there's a failure, going for laparoscopy. So that's basically how I tell my patient. But as I told you, I am a little bit in a beneficial side now, because insurance is paying, so we can choose HIFU over laparoscopic surgery.
And I think this is the last question for you, Dr. Selva. So for Thai doctor who want to start or who are interesting on HIFU, what should they do?
Okay, you see, I went through this. The difference is you must be committed. This is when I first went to Chongqing, that is in January 2019. I sat with Professor Zhang Lian. We all know who Professor Zhang Lian is. He's the biggest expert, and he's now the director of the HIFU hospital. So he told me something that is very interesting. He said, you do all your work, but every day you must do 1 or 2 cases. Then only you can become good. Because it is impossible to become good in anything if you don't do the cases. So I told Mr. Yu, I told Rosie, I told even Jenny, I said, I don't want to be a half-baked HIFU doctor. I want by 3 months to be able to do it by myself, not depend on anybody. So the only way I will be able to do that is to do cases as many and as fast as you can. I know that from past experience. I know that from laparoscopic surgery. I train laparoscopic surgeons. They come and learn from me, and then they go back, they don't do, they forget. So I said, I'm not going to do that. So what I did is I planned my work very, very carefully. I put all the things in place. It took me a long time to get all the organization. And I was lucky in the sense that my insurance covered me. And at the beginning was very stressful because I had to work with them and then they covered. So I could do cases very, very fast. And I did it. Dr. Huang was with me. The doctor was with me for 3 months, and we did almost 70 cases with her. And then after that, I did cases with Chongqing, and now I'm on my own. The last 90 cases, almost 100 cases, I'm doing it on my own. I can say that I am almost there with the experts. I know what I'm doing, and I know how to do it. Although at times I say, this one I should have called Chongqing. So the important thing here is, you must be committed. If you think you can come and do 1 case and then run away and do laparoscopic surgery or do IVF, it is not going to work. You will be like some doctors in Singapore, you're totally dependent on Chongqing to do the case. It doesn't work. So the most important thing is be committed. So that is the way to go about it. If somebody else buy and you expect to go once in a while to see, it's not going to work. I'm telling you, it is not going to work. All the Korean doctors are doing very well because all the centers belong to them. They got no choice. They have to do the cases. So, I still don't force my patient to do HIFU. I tell them, but they are all very happy to do. So I'm very happy to do for them. So if there is somebody who's really interested, first of all, the best way is if you can go to Chongqing and spend 3 months there. If you come back and if you don't have a machine, there's no point. And if you don't have the cases, there's no point. So you must plan it in such a way that you must have the machine in your place when you come back from Chongqing. You can go there 1 month. I only went there for 1 week. And I went there 2 years before that, So when I came back and the machine came, I was playing with the machine just to understand the concept. But I only started doing when my teacher came here. So, and then of course, Chongqing will support you. They will send you a doctor to do with you. But if you are not committed and if you don't do cases regularly, forget it. You're not going to become good. So that is my advice to doctors in Thailand. You want to be as good and as fast as me, do cases every day. Commit yourself. If you necessarily pay the patient to do it.
Buy the machine, right? Buy the machine.
You have to do the cases. Then only then you will appreciate, then you will learn, you become good, and you can appreciate to do it. when you're starting off, it's not easy. You got to convince the patient. You got to, you got to sit down with the patient, you got to convince the patient. You got to promote the product, and then you must make sure patients come to you. That's the only way to do it. I know in Thailand, they have been having this machine for 3 years, and I don't think the person can do by themselves because they're not committed. How to be committed? You must be convinced that it is a good product, and you must convincingly talk to your patient, not force them, but tell them, like I told you just now, I can do everything. I can do laparoscopic surgery. I can do HIFU. You see the benefit, you decide. If you want me to do laparoscopy, fine, I can do for you. But this is the benefit of HIFU. You want to do HIFU? 90% will choose HIFU, and 90% I'll be doing HIFU. So I'm doing much more HIFU. In fact, I do HIFU every day, except for Saturday and Sunday. I got no time to do HIFU because I have to see my patient in the clinic. I will do egg collection, I will do laparoscopic surgery, and then I have to do HIFU. So you got to find the time to do it. So that's my advice. Don't think you can get 10 doctors interested, but each one is doing once a month. Nobody will become good. I rather have 1 or 2 doctors doing this as much as possible, become good, then go to the next doctor. I think that will work better.
I see.
Yeah.
Thank you, Dr. Silva.
The Nigerian center is also, okay, I think the doctors from a Nigerian center, which is set up at the same time, similar period as the Dr. Silva, is also, that doctor is already independent, can operate on its own, okay? And now we are training the second doctor in the center, okay? So this is the way to go, yeah.
Nigeria center.
My good friend, a Nigerian doctor, Dr.
Ajayi. Dr. Ajayi.
Ajayi.
Yes, Olarik, he knows. He's your friend.
Yeah.
You have a picture together.
So I think the center is doing the 100 cases today or tomorrow, Nigerian center. Yeah. Okay. Yeah.
Right. So, Dr. Silva, we are very appreciate your talk. So, please give the take-home message for Thai doctors.
Okay. I mean, Thailand is a big country. Its population is almost twice that of Malaysia. I think my thinking is, what is it in for you? That is always the case in any. We all want to make a living. We all want to make money. Let's put it that way. You want to make money. I want to make money. And which is the best way to make money? That is the issue. For me, actually, I love laparoscopic surgery. If you ask me to sit in the operating theater from 8 p.m. to 12 midnight doing cases, I love laparoscopy. But I force myself to learn HIFU. The reason I think is because this is the future. So I want to be in the future. You see, and I want to be there in the future to be the pioneer. I don't know whether this HIFU will make me there, but so I committed myself to say that, okay, I will take this technology and bring it forward, and I will be the pioneer in my country. And so that's how I went about it. So the take-home message will be, this is a very good technology. Of course, it's not for everybody. It's not 100%, but it has got a lot of potential for a lot of patients, and patients love it. If money is not an issue, everybody will choose HIFU. In fact, people with endometriosis asking me, why not do HIFU for me? So they will choose HIFU, but we must give them the correct perspective. We cannot lie to them. We just tell them that, it is not 100%, but a high percentage you will benefit from this. So that is a take-home message. So we were not lying to patients. We are not pushing HIFU instead of laparoscopic surgery. Just like before this, we are pushing laparoscopic surgery instead of open surgery. So what we are trying to tell the patient is, this is the technology available, and you can decide what you want. If you do it that way, you won't get into trouble, and you're not pushing a new technology, but making them choose it for a patient. So in my mind, I think if you are forward-looking, you will try to adopt this technology early, and be the forerunner for it, And I think that at the beginning, as I said earlier, everybody cannot do it. It just like laparoscopic surgery when I started laparoscopic surgery in 1994. Very few people can do it. Very few people are committed to do it because there's not much money in it. In my country, if I do a laparoscopic hysterectomy, I do a HIFU or I do a open hysterectomy, the charges are the same. The government pays, the insurance pay me the same amount of money. But because I'm interested in laparoscopic surgery, I push myself. So now I become very famous in laparoscopic surgery. Now the same thing. I push myself to HIFU, I become famous in HIFU. So if you think that way, then it is worth it. But let me tell you that what you said is the time taken to do HIFU can be longer, especially at the beginning, because you're learning compared to laparoscopic surgery. You may wonder, is it worth it? But I'm telling you, it is worth it.
Thank you, Dr. Silva. Yeah.
So on behalf of the chair of this meeting, thank you, Dr. Silva, for your really informative talk. And I would like to thank you, Chongqing HIFU, to organize this meeting. So Rosie, can you talk something?
No. I already said what I need to say. I think this is a great way, and thank you, Dr. Silva, okay, for sharing your experience on the Facebook, on different venues, okay. And I think it's only the doctors like Dr. Silva and hopefully other doctors, okay, who are from the laparoscopic minimal invasive side, who has already learned minimal invasive technology, to share with the patients and the doctors their learning experience and how they think about this technology, okay. And I think this is the right way to bring this technology to the patients and to the doctor, okay. So we are very fortunate to have both of you, and I hope this technology will reestablish a good center, okay, very good center in Thailand soon.
Okay, so thank you. So see you soon for the next webinar roundtable. Okay.
Yeah. Okay.
Okay.
Bye.
Bye bye. สวัสดีครับ